Okay, sorry, my phone accidentally went off because my video was too long. So this is the rest of the video. Okay, I'm just going to start with number 16. The distal segments of each bone are grasped with large bone-holding clamps and pulled anteriorly and distally to expose the posterior muscles. The muscles are divided to the level of the bone resection in order that they retract to the cut end of the bones. This also exposes the posterior tibial and peroneal vessels as well as the tibial nerve. The vessels are doubly ligated and divided. Using the listed knife, the surgeon cuts the graciolus muscle in a bevel fashion so it forms a flap that is long enough to go across the end of the tibia. The ends of the tibia are smooth and round fashion with a rasp, and the area is fully irrigated to remove all bone debris and dust. And at this point, the CST must be listening extremely well because the leg is now completely amputated and is handed off to the circulating person. But the CST should verbally confirm if it is the right or left leg. The CST must be prepared to keep up with the surgeon and should have plenty of laps to help soak up blood and aid in exposure. The tourniquet is released and the bleeders are clamped and ligated or cauterized. The control of bleeding is important prior to suturing the flaps over the ends of the bone. The surge tech must have several ties and clamps ready for use. The surge tech may be responsible for using cautery on a clamp and removing it while the surgeon is placing clamps on the other bleeders. The gastrolius muscle flap is brought over the ends of the bones and sutured to the deep fascia and the periosteum anteriorly. Then the hemovac drain is placed deep in the muscle flap and fascia and brought out laterally in the skin, approximately 10 to 12 centimeters proximal to the end of the stump. And lastly, the skin flaps are trimmed with the knife blade and metamom scissors in preparation for suturing. The skin flaps are brought over the muscle flap and sutured together with non-absorbable sutures. And then there's a video. I'm not going to show the video because my video is already way too long, so you guys can just look at that when you have time. And then complications are you can get post-operative surgical site infection. You can get the phantom limb syndrome, causing a perceived severe pain, chronic effusion, and necrosis of tissue. And then what have I learned? After observing and researching a below-the-knee amputation, I have learned that it is actually performed very quickly, despite how long my video has been. But it's actually performed very fast, and but I went into a lot of extra detail. In order to control hemorrhaging, the CST really needs to be prepared for lots of bleeding and have plenty of supplies needed for that and for clamping off vessels and nerves. So just basically you need to really watch the surgeon and make sure you have all that stuff prepared in case something goes wrong and there's lots of bleeders. Alright, that's the end of my video. Thanks, guys.